case, we're using a clamp number 4, which will go on tooth number 14. This side of the clamp will face the lingual, and that side of the clamp will be on the buccal. You want the extra floss to come out of the buccal vestibule. Taking your floss and thread it through the lingual side of the clamp first, and making a slip knot. And then wrapping the floss across the bow about 3 times, taking the end
Not this clip edge
through the other hole. This is how your clamp should look once it's properly ligated. Removal is very easy. Simply use a scissor to cut the slip knot on this end. And the floss will come unraveled.
Okay. As we go through these slides, if you have questions, please bring them up as we go through the material. Any questions so far on this video? Okay.
I'll give you a question.
Oh, yeah, sure.
How do you tie that to the frame dam there?
Oh, how does it attach to the frame?
Yeah.
Which, if you're using a hygienic frame, for example, the radiolucent frame, you can undo a corner of the dental dam and take the floss and wrap it around the frame and then reattach the dam on the frame. I think I might have shown it in some of the videos that's coming up. I can't remember for sure, but I think I did. But that's how you could do that. If it's a metal frame, you can also do the same thing. You just wrap the floss around the metal frame a few times, and if the clamp dislodges, it won't go very far. It'll just hang from the frame.
But how about the framed flexi dam?
Well, on the frame flexi dam, there's no place to really anchor it. It's just going to lay outside of the buccal vestibule, outside of the dam. So yeah, there's no way you can do that. I shouldn't say there's no way. I mean, if I suppose you can make a little tiny a hole in the dental dam with the punch, and then, you know, pull the floss through there and, you know, and secure it, tie it in some way. But the thing is what would happen there if the clamp did become dislodged, it could possibly fly across the room. But the biggest thing is having the floss on the outside of the dam, so that if the clamp did break into 2 pieces, for example, you would be able to retrieve all of the pieces. Does that help?
Definitely.
Okay. All right. Now, what I'm going to talk about next is your posterior quadrants. Again, on your left are the main points I want you to get out of this video, and we'll go ahead and play that.
I will now demonstrate quadrant isolation using the frame flexidam. I've made holes for teeth 7 to 14. The teeth to be treated will be 9, 10, 11, 12, and 13. Using a winged clamp, I insert the wing clamp into the dental dam. And I will place water-soluble lubricant on the tissue side of the dam. Inserting the clamp forceps into the dental dam clamp and going to the mouth. next step is to stretch the dam off of the wings. And then carry the dam to the opposite side. Using a wedge cord to anchor the dental dam into position. You trim the wedge cord. The next step is to use the knife edge concept. What this is we're taking the edge of the dental dam and we're going to slide it between the teeth. And we continue to do this until the dam is through the contacts. Now generally, the contacts are too tight, the dam should slide right in. But in the posterior region, we normally need to use wax dental floss. Taking the wax dental floss and taking an edge through first, looping the floss and taking a little bit more of the dam down through the contact. And repeat the procedure until the remaining interseptal dam is through the contact. Notice we're taking an edge of the material through first. Don't bunch it, as you would be trying to force too much material through the contact at the same time. We're just feeding an edge through first, and we have to repeat the loop technique several times in areas where there may be some tight contact. And now we're going to the last one here. Here we go. Always make sure you have the entire interseptal dam through the contact. If the dam is not thoroughly placed between the teeth, you'll have difficulty inverting the dental dam. Now, usually when it comes to inversion, I would suction everything dry, and then I would use my instrument. Hoping I have an assistant, I would simply place the instrument at a 45-degree angle and turn under the dental dam. Now, number 9 is going to have a cervical lesion that we need to have a gingival retractor clamp placed. So I'm going to show you a trick that I use to invert, to make sure that I get a nice inversion. I'm using some dental floss to floss the distal and then floss the mesial. I wrap the floss around the cervical area of the tooth, tuck the dam down on the lingual, and then to invert on the facial, cross your floss and gently tuck in a gingival direction. Uncross the floss, come back out through the contact, and you can actually go on to the next tooth if you so desire to do so, and repeat the process. Again, tucking the floss and the dam in a gingival direction, gently of course, and then cross the floss and gently tuck. Uncross it, come back through the contact, and then you can come through this way. And that's why we trim our wedge cord. All right, so I'm nice and inverted, and the next step, normally the doctor would go ahead and prepare the teeth in the posterior region. When it comes to the number 9, that would be prepared last. Let me just show you the difference between the two Brinker retractor style clamps. This is a B5, and this one's a B6. The difference being is that the jaws, the width of the jaw on the B6 is a little bit wider than on the B5. So therefore, the B6 is placed on the upper anterior teeth, basically your centrals more or less, and the B5 is for your lower anterior teeth. Now notice these do not have holes. Instead, they have notches. So So let me demonstrate how to use this clamp. With my non-dominant hand, I hold the clamp. I'm in chair side position. My dominant hand engages the notches closest to my dominant hand. And then I'm going to come in and I'm going to gently glide the clamp into position until it's seated down at the gingival area. Notice how it retracts the tissue very nicely. These are never used by themselves because, you see, they have a tendency to rock, and therefore they are not intended for use as a single isolation clamp. So theoretically, the number 9 would be prepared and restored, and once that is completed, the number B6 clamp is removed, again engaging it into the notches. And I'm going to come in from a different angle. There we go. And then, upon removal of the dental dam, the wedged cord is removed. You may use a cotton forceps to do that. Placing a finger in the buccal vestibule to protect the tissues. And pulling the dam away, making sure to cut each and every interseptal dental dam. Now, sometimes the projection, this projection here on this clamp might prevent you from getting access to cutting this last interseptal piece of dental dam. So the idea is not to try to remove the clamp if at all possible. So what you can do is sometimes you can just get an instrument to pull the material away like this, and then just cut the interseptal dam. And then the clamp is removed last. The dam is removed. And check for missing pieces. Notice that all the interseptal dam is present. If there's a missing piece, you need to retrieve it with dental floss and then bring it back to the dental dam and match it up. This completes the isolation.
Are there any questions on this technique? Okay. We'll move along to the next. All right, so in dealing with their anterior isolations, I'm going to, this particular video will show you using the wedged cord, and I think I might have also showed you the little trick on using a wedged cord if you have a tight contact. So let me go ahead and play this video.
I will now demonstrate an anterior quadrant isolation using wedged cord. I pre-mark my dental dam and place the dental dam on a hygienic radiolucent frame. This is much easier to punch the holes when it is on the frame. Adjusting the hole sizes for the particular piece in question. I now place water-soluble lubricant on the tissue side of the dental dam. This facilitates placement of the dam between the teeth. I go to the patient's mouth and using a wedged cord, anchor one end. I carry the dam to the other end of my isolation. With tight contacts, it's easier to pass the dental floss through the contact, passing dam through the contact with the floss. Make a loop. Apply your wedgie cord through the loop. Fold the wedgie cord over. Pull the 2 strands of floss. Pull the long end of the wedgie cord and pull the short end through. You may now cut the wedgie cord. The next step is passing the dental dam through the contacts. Line an edge up first and pull the dental dam through the contacts. If the contacts are not too tight, the dental dam should slip into place very easily. You want to carry an edge through first and pull the rest through. You're feeding the dental dam through the contacts. Just to make sure all my dam is thoroughly through the contact, I'll go back with my floss and I will refloss the area. If you notice, as I'm using my loop technique, I'm actually trying to invert the interproximal dental dam at the same time. And you can see how it's turning under simply by using the floss method. If I have a dental assistant to help me, the dental assistant will blow air from the air-water syringe at the cervical area as I invert the dental dam using a composite instrument. Another trick to floss and invert is using this method, flossing around the distal and the mesial, and then tucking the dental dam and the floss on the lingual with a composite instrument, and then crossing the floss gently, pulling in a gingival direction to invert on the facial. Bring the floss out through the contact, and you can go on to the next tooth and repeat the procedure. Normally, if I'm working by myself, I use this method to invert. It gives me a very nice inversion on the anterior, particularly if we're doing restorative treatment that involves the cervical lesions. If they're not too subgingival, this works very adequately to invert and give access to those preparations for those lesions. There we go. So the isolation is thoroughly complete. Once the treatment is completed, the wedgie cord are removed. Simply pull through the embrasure area. This guy's a little tougher. There we go. Remove your wedgie cord. Protect the patient's lip. Pull the dam away and cut each and every interseptal dental dam. Making sure the entire blade of the scissor encompasses the interseptal dental dam. Remove the dental dam with the frame intact and take the dam off of the frame and check for missing pieces. As you can see, all the pieces are intact. Any missing piece should be retrieved from the mouth and placed to the area in question, and make sure that you have all the pieces. This concludes this demonstration.
Okay. Any questions with this isolation? Okay. All right. So let's look at some other issues that can be problematic for newly placed dental dam, people with experience with newly placed dental dam. So, for example, we're looking at preventing dental dam leaks. All right, so one of the main reasons could be because the dental dam isn't stretched off of the wings. So it's very important that after the dam is seated, that the dam is stretched off of the wings of the clamp. Another issue is the spacing between the holes. Some people think that if the dental dam, interseptal dam is thinner, that it's going to make it easier to apply it through the contacts. Well, yes, in reality it is, but on the other hand, what happens is you don't have enough material to cover the interdental tissues and also to invert, so you're going to get leakage. So the spacing that are on the templates and the stamps are adequate spacing to provide you good inversion and prevent leakage. The other issue is the hole size. In our literature, we show this similar diagram as to what holes should be punched for the specific teeth. Now, I did notice that on your non-latex dental dam, because the modulus has been altered, that sometimes what happens if the holes that are recommended to be punched for the latex material, some people have issues where there's leakage around a non-latex dental dam using the same size holes. So what I've normally done is said you could punch the holes one size smaller when you're using a non-latex product, because the dam does stretch and it doesn't quite come back to its original dimension. So if you have someone that's saying, hey, you know, I'm punching these holes and I'm getting leakage, you may want to check to see what hole sizes they're punching. I know that also sometimes some of the dental schools, they'll say, okay, for the anchor tooth, we're going to have you punch 2 holes, and they make the hole really way too big, and then the dam will leak. So that's another issue. Now, again, leakage could occur if you do not have the dam properly inverted. Now, I showed you several techniques in the previous videos how the dam could be inverted. So if you're having someone that's indicating that, say, hey, I'm inverting the dam, but it doesn't seem to want to stay under, then I would show them that floss inversion technique that I showed you a couple times, because that works really well. But make sure that they're punching the correct hole sizes. The whole idea is that if the hole size is too large to encompass the necks of the teeth in it should be a snug manner, then you're going to have difficulty inverting. So those are kind of issues that might help you for those questions. Of course, we know about the wedges dental dam stabilizing cord. Now, remember we were talking about if you had no contact that you can't use a wedget cord. And this is true. You need a contact for it to work. In the slide to the far right, this particular operator, as a matter of fact, is Dr. William Liebenberg's slide that I got this idea from. He would tie a floss to an anesthetic plunger and use that to ligate around the last tooth as a means of retaining the dental dam. And of course, you could use a wedget cord in the anterior part of your isolation. Now, depending on where the carious lesion is, that little plunger could become an issue, but it can be turned and placed in such a manner where it wouldn't be a problem. But that's an option for someone that doesn't want to use a clamp in the last tooth. Now, structurally compromised teeth. We talked a little bit about the serrated jaw clamps, the 12A and 13A. And again, just to reiterate, the bigger side of the jaw, the big jaw, goes on the buccal aspect of the tooth. And the serrations give that clamp more gripping power. 14, 14A, and your 8A will also work for a case where the tooth is partially erupted as well as being compromised. So because the 4-point contact subgingivally is what keeps that clamp in position. Now the B1, 2, and the B3, I like these clamps. They're part of the, as you know, the Dr. Brinker's selection. Excuse me, the B1 actually was designed to be used on the lower arch, and the B2 and 3 were designed to be used on the upper arch. Notice that the jaws are offset on the B2 and B3. There's the one side's larger than the other. So again, the wide side goes on the buccal. These are really good when you have a cervical lesion, whether it be on the buccal or whether it be on the lingual. They retract the tissue out of the way so you could get access to those areas. Now, these 3 clamps can be used as regular retaining clamps. They are sturdy enough where they'll stay on by themselves. I use the B2 and B3 for sealants. I normally use a little topical on the tissues, and I would use the B2 and 3 when I was doing sealants on children. I would never use a 14 or 14A on a child that hasn't had the area anesthetized. So the B2 and B3 are tolerable when you use some topical on the tissues. And it does give you access to where you need it also for the carious lesions. Of course, you know, if you're doing carious lesions, they're going to be anesthetized anyway, but I'm talking about the sealants. They will stay on. So that's kind of how the clamps that you would recommend if you're having those types of issues. Do I have any questions regarding the clamps for this kind of an issue or anything? Anybody? Okay. Just speak up if you've got a question, okay? Excuse me. Now, I think another issue came up is, as you can see in the top slide there, we have a very, very structurally unsound tooth. We're actually, I believe that's a bicuspid, if I think it looks like a bicuspid. This slide actually is, some of these slides are from Dr. Liebenberg's collection that he was kind enough to let me have. We're actually using a number 9 clamp, and what's going on here is that we actually have 3 teeth that we exposed in this isolation. The dark material on either side of the clamp is green stick compound that we're using to stabilize this clamp, and they're being stabilized on the 2 teeth that are beneath it, so that this clamp should be stable and not pop off. Because of its structural integrity, I should say that's not there, it's very easy where this clamp could become dislodged. So that is what was done there. Also, by including the 3 teeth, it takes the tension off of the center isolation. So that's one way of stabilizing and using a number 9 clamp on a tooth that is otherwise you wouldn't consider using a 9 because of the size of the tooth. Now, also in the middle section, again, you can see those teeth were pretty badly in terms of structure. What Dr. Liebenberg did, he actually took a number 9 clamp and he sliced it in half. And on one end, he made a pilot hole in the rubber plunger with a number 4 burr and placed the jaw of the clamp into the plunger. What that does is it helps cushion the clamp against the tooth structure. And of course, the facial aspect of the clamp is engaging along the tooth surface. Again, compound is used to stabilize this clamp. These are very precarious situations here, but it just shows you that what can be done when you do have situations such as these. Now, the other slide that is in your lower right, again, we're using a number 9 clamp, and so therefore we again included several teeth in the isolation, so that the tension is not focused on the one single tooth being isolated. Any questions on these?
Mary, what was the name of that material? You said the green stuff in the top slide.
Yeah, it's green stick compound. It's got this material is older than the hills. It comes in green and it comes in brown, and they look like sticks. You know, they come in like a cylinder stick. And what the original purpose of the green stick compound was, when they made dentures and they used to do border molding. You guys are familiar with border molding, right? Where they would lay the material along the edge of the tray, for example. And what the purpose of that is so that you could get, when you put your impression material into the tray, you can get a nice registration of the buccal fold, okay? So that's what that material used to be used for. It may still be used for it if they're making dentures, but things have changed so much. But anyway, the point is that you would heat it with the flame, and then what you would do is, at that point, you have to place it in a little warm water to kind of temper it so it's not as hot. You kind of bring the temperature down slightly. And when it's in a taffy state at that point, with a wet gloved hand, you can pull a piece of it off, and then you can mold it around the bow of the clamp and over the adjacent tooth. And then you use the air water syringe, the air, to cool it. And when it hardens, it's very hard and brittle. So to remove that, you could get a scaler and you can just flick it off with a scaler when you go to remove it. And so what it does, of course, is it gives additional retention of the clamp so that it's not going to pop off. Because as you can see, it's a very precarious situation here with the structure that's remaining. And that just adds added protection of keeping the clamp from popping off. So yeah, it's green. It's called green stick compound. Hygienic made it. I think, I think they still make it. It's I'm not sure. I don't get your product brochures anymore either. So and not much of the older stuff is on the website. So but I know, I'm pretty sure Hygienic used to make the green stick and brown stick compound. Okay.
Cool, thank you.
You're welcome. All right, so in other areas that you might find people saying, well, I'd like to use DAM, but I do my interproximal restorations and the matrix bands sometimes become an issue, or, the first thing is they'll say, okay, so I got my nice quadrant and I'm going to prep my tooth and I tear my rubber dam. I had done some programs for Garrison, and this is kind of, this comes from some of the material I had provided them for a webinar. Basically, they're fender wedges. I don't know how much you're familiar with their products, but it's a little metal wedge that what it does is basically protects the interproximal so that, and it also protects the tooth. So when the preparation is being done, you're not going to nick the adjacent tooth, and you also won't tear the dental dam. So that's an idea there. The other thing too is, and let me see, I'm getting a partial. Oh yeah, on the upper right side of your screen, you'll see me, what I did there is we had like an interproximal on the molar, okay? So you can actually use a composite instrument and you lift the interproximal dam from the molar and premolar and place it between the two premolars like I did. And what the idea is, the preparation would be done, and then after the preparation is done, you can replace the interproximal dam back where it was supposed to be to begin with. Now, if you did nick the dental dam in that one spot, you can just turn it under. That little one interceptal dam isn't going to make that much difference if it did get snipped accidentally. But those are two techniques that you can use, either the fender wedges or just simply replacing the interceptal dam in an adjacent contact area and then placing it back. Now, the other thing is, on the matrix options, with those sectional matrices systems, when I was practicing dentistry, we didn't have some of these matrices. These are really nice matrices, believe me. But the interproximal, the sectional matrices make it much easier because you don't have the Toffelmeyer, the Toffelmeyer that would get in the way of your restoring, and also sometimes it would run into interference with the clamp and that kind of thing. So those interproximal sectional matrices are really, really great. And then you see, like the last tooth in the arch, you see that real matrix on the adjacent slide there, the real matrix system. Again, when not having to have a Toffelmeyer, that real matrix works really nicely because it's less obtrusive and it doesn't run interference with the clamp and that sort of thing. So that's another option. The other thing is they have separating and the wedging. You have their composite type system and their separation rings, and they can be piggybacked, as you could see there. They had the different heights. So the other thing that I liked about their little wedgers, did you see on the lower right image? Do you see like the little filaments on the wedges? They work better than the wooden wedges, because we didn't have those. We used to use wooden wedges. But these are really neat because the little fins, if you want to call them, they'll stay in much more readily, particularly when you're using a dental dam. You need to have something that's going to grasp in interproximally. So those really work very nicely. So I don't know, do you guys get much questions about using dam with bands and stuff like that? Anybody get any questions about that? I guess not. Okay, well anyway, so that's that on that. All right. So basically, incorporating dam doesn't have to be complicated. It's just a little imagination and ingenuity. And I hope these helpful hints and suggestions will help you with guiding your doctors into using dental dam and encouraging them to use dam, and so that it doesn't seem like it's so overwhelming. Do we have any questions on this part of the presentation? Okay, let me open up my other one. We're going to get into more advanced techniques here.
Hey, Mary.
Yes.
This is Kyle. I do have a question quickly related to the last one. There was an area that you talked about, and I think even showed cutting a particular clamp in half.
Oh,
And
yeah.
Since we would probably ask that, dentists don't do that with our clamps because that would disregard or kind of annul any sort of defectiveness guarantee. Would there be another way or method that we could suggest instead of doing that?
You might want to find, perhaps in that situation, you might be able to get away with a 00 or a 0 clamp, which is basically
Okay.
small bicuspid clamp. You might be able to get that to stay in position. Yeah, I understand what you're saying. These, like I said, Dr. Liebenberg was well, I'm assuming he's still practicing now, but at the time when I was affiliated with him, he used dental dam. I mean, I can't think of cases where he may not have used it. And those were, he lectured extensively on dental dam. And so that was some of the things that he was showing that he did. But I understand coming from our point of view. Yeah, I think the 00 or the 0 clamp may stay. It just depends on the tooth. Also, if it's a bicuspid that's badly broken down, you might get the 2A to stay as well. But I do strongly suggest that if you've got something that's structurally compromised, to isolate a tooth on either side, because it relieves the tension on the tooth that is structurally compromised. And you could use wedget cord, on those either end. You know what I'm saying? You don't have to use a clamp. But that's what I would recommend, is to ease that tension. Because the more tension you have on that single isolation, the more of a chance that the dam could pop, the clamp becomes dislodged and it could pop off.
Okay, perfect. Thank you.
Okay. Thank you for bringing that up. Again, yeah, I appreciate that. Okay, let's see. Let's go over here to here we go. All right. So we're going to look a little bit at these clinical situations. And so let's go through these. All right. The number 9 versus the gingival retractor clamp. I have seen textbooks where they're showing a gingival retractor clamp for an endo isolation, and I cringe, because you saw how on my video how that B6 kind of wobbles. All right. Well, those clamps are just meant for gingival retraction. The 212, the B5, the B6, and the B4 also are simply for retraction purposes only. They should not be used as a retaining clamp. So the important thing is also, you see how the number 9 is positioned on the tooth. The ski slope goes to the facial aspect of the tooth. I've also seen textbooks show this clamp on backwards. All right, so again, the Brinker tissue retractors, Dr. Hunter Brinker, he's deceased now, unfortunately. He does have a son, too, who I met as well. And I had the opportunity to meet those two wonderful people. They're really great people. Anyway, but the Brinkers, as I said, the B1, 2, and 3 can retain the dental dam. The 4 was, Dr. Brinker used that for crown preparations, and I think that I haven't had the opportunity to use it for that purpose, but I guess it worked very well. As a matter of fact, we had a question on the Dr. Bicuspid course, and there were some hygienists that wanted to know, well, can I do quadrant scaling with the rubber dam in place? And actually, the answer is yes, you can. And you might think, oh my God. Well, actually, you just think of the dental dam as being as part of the tissue. And, just get your scaler down between, down into the sulcus. And so my understanding too was that Dr. Brinker's hygienist did use the dental dam for quadrant scalings also. So anyhow, so we're talking about the B1, and we have a class 5. We're trying we're showing it. Yes. Does someone have a question? I'm sorry, you're breaking up. Okay. Are we okay? All right. The slide across from the Brinker retractor clamps is basically showing you the clamp in position for a class 5 restore. So it does retract very nicely. Now, when you have an issue where you have a cervical lesion that, let's say you don't need a gingival retractor clamp, okay, but you do need to restore the cervical lesion. Again, this is from the Garrison presentation that I did using their cervical matrices. I don't know if you guys are familiar with these matrices, but they're really nice because of the fact that they practically complete the finishing process on its own, except for some minor polishing. But anyway, the point is the matrices systems will also provide a little retraction when you're restoring a cervical lesion. So any questions on the slide? Okay, let's continue. All right, the last tooth in the arch. So people say, well, I can't put the DM on because I'm going to restore the last tooth in the arch and it's just going to get in the way. Well, there's several things that you can do. Number one, you want to use a flat jawed clamp. And the reason why is because you can usually get a matrix system in place if the jaw of the clamp is flat and not curved or cupped, like say an 8 or a 4, for example, has a little more curve to the jaw. The idea is to keep the clamp in place and also get your matrix system in place. So there's also what they call distally extended clamps. The bow is distally extended. Usually those are indicated by a D after the number. Ivory, I think, used to make like a 14 AD. And I'm not sure, I don't think they make that anymore. But some of the bows are a little more distally extended than others. Unfortunately, we really don't have a clamp that has a bow that's more distally extended. But the other option, of course, is we can reverse the bow. Like if you have a DO, and well, in this case, we had an MOD. You can reverse the bow of the clamp, and you get the dam in place normally. Then what you do is you reverse the clamp after the dental dam is secure. And with a surgical burr, you can go ahead and do the preparation. You need the surgical burr length in order to get access to that distal, because your handpiece has to go over the bow and drop into place. So that's another option. Once the tooth is prepared, you can reverse the clamp so the bow is back to the distal. What happens is that distal flap of dam does have a tendency to fall forward when the clamp is positioned with the bow to the mesial, but you can have the dental assistant hold the end of a mirror handle against that dental dam to retract the material while the preparation is being done. So that's another way of conquering this particular situation. Any questions? Okay. All right, whitening procedures. With the whitening procedures, you can basically do a traditional isolation with a wedget cord. You want to check the patient's smile, make sure that you're going to be including teeth that they're going to show when they smile, and that include those teeth so that they could be whitened. So I normally carry the dental dam to the second premolars generally, and using wedget cord. Now there's a product called Oral Seal Dental Dam Caulking. Ultradent makes it. When you use an isolation, like particularly if you're turning under the dental dam for the alternate isolation of the general field, you can also lay a little bit of the Ultradent's Oral Seal material along the vestibule area, and that helps seal the dental dam a little bit more so. Also in the other shot, where they flip the dental dam down and they're adding the Oral Seal caulking material as added protection and seal, and then the dam was flapped back in the normal position. So those are alternate methods of doing the whitening procedures. Now, the other issue is isolating around fixed bridges. There's a technique that's a floss ligation, and I think you can see how the floss is flossed through the embrasure area on both sides of the interseptal dam, and then it's tied off on the facial aspect of the teeth. Now, that is a little bit more involved, and probably most people wouldn't bother doing that procedure. Again, this is a Dr. Liebenberg procedure, and this gives you the best isolation. However, there's another option. The other option is to use wedget cord. And as you can see, we didn't punch a hole for the ponic, and we're just sliding wedget cord on either side of the ponic. So that's an option. And then the other option would be the general field isolation, which you can do the 3-hole, or the 2-hole is simply punching 2 holes and making a slit across the whole area. I think you get a little better isolation if you do the 3-hole technique, which I know that we did a video on that in our previous presentation. Any questions here? Okay. All right. The other issue is when you're doing a fixed bridge or crown and preps, whatever. All right. So, of course, you want to take your pre-op impression for your temporization and your bite registration. In this case, what we're doing is we use the general field isolation here. In reducing the tooth in question for the crown prep, we're using the bite registration to get an idea of how much of a reduction we need to do for the crown. And then we're using our retraction procedure. And then the last slide is showing you using the your pre-op impression for your temporization. So all this can be done using the general field isolation, and of course we know that we have to use a non-latex dental dam because if we're using the polyvinyl chloride impression materials, that's going to interfere with the latex material, so the powder. So anyway, that kind of gives you an idea there. Any questions here? Okay. Now,
Mary, sorry, can you just repeat what you said about the impression material and latex?
Yeah, you have to use non-latex dental dam because the polyvinyl chloride interferes with the powder that's in the, if you're using your standard latex dental dam as powder, it won't set.
Gotcha, okay, thank you.
Yeah. Okay, so I know this is a little elaborate, but it can be done. Actually, I did, one of the practices I worked in, we did do this. We did an upper and lower isolation. The first one is just for class 1 restorations or sealants. You could just do single tooth isolations, upper or lower arch. You want to place the clamp on the upper arch first, and then the lower arch. And then if you're restoring both in upper and lower quadrants, what you would normally do is you'd place your upper clamp first, and then you would go ahead and place your lower clamp. And then you would go to your anterior on the upper arch, place your wedget cord, and go to the anterior on your lower arch, place your wedget cord, and then you could go ahead and use your loop technique and your knife edge concept to get the dam between the teeth. And so anyway, it can be done, maybe a little elaborate, but it can be done. By the way, the one here for this sealants, when I was teaching the hygiene students, I would teach them how to use this isolation when they're doing sealants. All right, so we talked about multiple quadrants. You already saw the upper lower. The top one is an upper arch. It's actually a cross arch type of a deal. That's a Dr. Liebenberg slide. I know the quality of that slide isn't that great, but I didn't. I wanted to show some clinical stuff too that actually was done in the mouth, but I suppose I'll have to really do that on a typodont so that it looks a little better. But anyway, the point is that it can be done, and you would basically go ahead, as I said, securing the clamps and so forth. Anyway, these are situations that you can do. This would work best if you use the frame flexodam too. Now for ortho, there we go. You can do a traditional isolation where you do the entire arch like that. You can do a floss ligation. Say if you have a patient who already has the bracket in place, this was used as a floss ligation around the brackets. What happened here, as you can see in the bottom slide, that person required endo in those anterior teeth. And you can also do a general field isolation. Now, what's going on there actually is there's a piece of dental floss that's going through a piece of cotton padding where holes were punched. What that cotton padding is doing is it's occluding the open space that happens when you just do a 2-hole isolation, because there's a big, huge gap open on the lingual unless you occlude it in some manner. And so that was occluded with some dental floss. You can see where it ties on the bracket, on the brackets there on the facial. So anyhow, these are means of isolating when you have your ortho cases. Now, another option when you're doing the bracket bonding, for example, here we go. This is sort of a modified general field isolation. Now, what we did is the last 2 holes are going to receive clamps, as you can see in the image on the right-hand upper right. So we punched a hole for the clamps, then we punched a hole mesial to those, and then we punched a hole for the canines, and then on either side of the canines we punched a hole. So we're going to make a slit, as you can see. What we did is we made a slit between the mesial hole on the molar to the distal of the canine, and then we made another slit in the anterior. The reason why we want to have dam on the distal and mesial, interseptal dam on the distal mesial of the canine is so that we don't have such a wide gap in the lingual area of the dental dam. So when it's applied, you can see in the image on the lower image how it's going to look. You're going to have the material inverted on the buccal and linguals in the posterior and the anterior. And you can see on the slide to your far right, lower right, there is a little bit of a gap there, but it's not too bad. It would have been worse if we didn't make that interseptal material on the either side of the canine. So anyhow, so these are options for bracket bonding. So what I've showed you are cases where perhaps dentists may not routinely use dental dam, but the thing is with the emergence of infectious diseases, we might want to consider using some of these methods that we would not otherwise use. And if you do get questions on, well, you know, how can I use this for this or that, I'm hoping that these recommendations have helped. And of course, you can always email me. I'll be happy to answer your questions. Just because I'm no longer an employee at Colteen doesn't mean that I'm not willing to help you guys. So please, if you have questions, email me and I'll do the best to answer them. And I want to thank you all for your attention today. Any other questions?
Nope. Okay. Thanks, Mary.
Thank you very much, Mary. Very informative. Thank you.
Mary.
Thank you.
Thanks for all your
Thank you,
time.
Mary.
Absolutely. Mary.
Appreciate you. Thank you.
Okay.